Thank you for choosing Axxess On Demand. We're the fastest growing home health technology company, helping improve care for more than 1.5 million patients and trusted by more than 7,000 healthcare organizations to grow their business. Axxess is a firm believer in continuing training, and we create content so you can learn and grow anywhere, anytime. Let's get started.
Good morning. Thank you for joining us for this live webinar to help you prepare for upcoming changes associated with the implementation of Patient-Driven Groupings Model, or PDGM. Today, we will discuss how data analytics can provide you the roadmap you need to successfully transition to the new payment model. My name is Stephanie People. I'm the Senior Director of Brand Marketing at Axxess. Before we get started, let me just tell you a little bit more about Axxess. We are a leading and fastest growing home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Today, you will hear from industry expert Aaron Little, a certified public accountant and leading national home care and hospice consultant. Aaron has over 20 years of experience with BKD and oversees the operations of BKD healthcare billing and revenue cycle services, a special team that manages the billing and revenue cycle operations for more than 100 home care, hospice, and senior living organizations throughout the nation. Active in numerous home care and hospice organizations, Aaron is recognized nationally as a thought leader on matters related to the Medicare home health patient-driven groupings model, and frequently asked to speak on related topics. Also joining us today is David Merck, Executive Vice President with Axxess. David is the founder and CEO of Home Health Gold, which has been providing Medicare certified agencies with extensive data analytics and OASIS scrubbing tools for over 20 years. Prior to launching Home Health Gold, he worked for 11 years as president and CEO of a large VNA in Central Maine. In March of 2018, David joined the management team at Axxess as part of the acquisition by Axxess of Home Health Gold. Before we get started, just a couple of quick housekeeping items. Everyone's phones are muted. However, you may submit questions through the webinar. If time permits at the end, our presenters will go ahead and answer as many questions as possible. If we don't have time to answer yours, don't worry, we'll follow up with you following the webinar. Also, after the webinar, and also noted in the questions that have come in so far, we will be sending out a link to the slides as well as a recording of today's webinar. And we'll also post it on axxess.com.
We're going to talk a bunch today about data and its relevance under PDGM. PDGM is a significant change, and it's important to look at how you're doing now, how you might do based on how you're performing today, and how PDGM will impact your agency. You may want to identify metrics that you want to track ongoing as you get into PDGM to make sure that you're on course, and to learn where there are opportunities to better serve the patients who are being targeted by CMS. It's really important to begin now. Some of the changes that need to be made, some things that haven't even been being mentioned by CMS with regard to PDGM will take time to change. PDGM has a number of features in common with PPS and some significant changes. The concepts of HHRGs, HIPs, outliers, and LUPAs are retained. HHRGs are based on the primary diagnosis plus other patient-related items under PDGM. Functional deficits, for example, contribute, but account of therapy visits does not, and this is a significant departure from past reimbursement systems for home health. As many as 24 secondary diagnoses can be included on a claim, and they now figure in the calculation, particularly as it relates to a comorbidity score. Payment is made for a 30-day period, not a 60-day period, but it's based partly on data from 60-day assessments, and so we often talk of 30-day payment periods and 60-day episodes. There are 432 HHRGs under PDGM rather than 153 under PPS. And each of the HHRGs has its own LUPA threshold, ranging from 2 to 6 visits. So there's a lot of stuff to keep track of here. Under payments in the past, services really did figure heavily, but with PDGM, it's all about the characteristics of the patients. And CMS has provided us with a graphic here that gives us an idea of how the 5 types of determinants all fit together. The first things to take account of are the admission source and the timing. As regards admission source, is it a community referral or an institutional referral? Definition of an institutional referral is that it comes from one of the selected types of institutions and happens within 14 days prior to the start of the payment period. The thing to remember about the early-late, the timing issue, is a payment period is early if it begins following a 60-day period in which there was no home health service under Medicare, and it's late otherwise. So by definition, an episode, a 60-day episode, may start as an institutional and early episode, but it will be a community late episode for the second payment period. The next factor that's critical is the clinical grouping. As I noted, the primary diagnosis is extremely important. They're taking the one from the claim, but obviously your OASIS gives you a pretty good idea of what it's going to be. And they've developed 12 clinical grouping categories, and each of these has a different case mix amount assigned to it, and ultimately, therefore, leads to a different level of payment. And assignment to those groups is based strictly on that primary diagnosis. Next, we have the functional impairment level, which can be from low to medium to high based on the several questions, 7 questions altogether in OASIS. And that is the one thing that comes very directly from the OASIS assessment. Lastly, we have what's called a comorbidity adjustment based on secondary diagnoses, a rating of none, low, or high, indicating conditions that compound the condition indicated by the primary diagnosis. All of these things kind of figure together so that, 12 times 2 times 3 times 2 times 3 gives you 432 combinations. And generally speaking, the conditions carry across the 30-day periods, except that, as I noticed, both referral and source and timing will change automatically. Secondly, if there's a significant change in condition during the first 30 days, that can impact diagnoses and institutional status with regard to the second 30 days. The whole calculation of dollars in this under PDGM for the 30 days is familiar. You've got a standardized rate, which right now we're talking about a rate of $1,883. It's based on 2019 levels and will probably change by January 1st. And CMS would like to include within that a behavioral adjustment, reduce it by another 6.42%. But that is a decision that has not yet been finalized and is being fought arduously. We've got that standardized rate, and at this point, we're going to work with the $1,883 rate. And then each HHRG has an assigned case mix. You take the 2 of those, put those together with the labor rate for the area where the patient resides, and factor those in the same way as is done under PPS to get the dollar amount. The key thing to remember right at the start is how critical the primary diagnosis is. If you have a diagnosis that does not fit on the list of 43,000 that are accepted by CMS, you will get no payment whatsoever for the episode. It sounds like 43,000 ought to be a lot, but in fact, currently we work with another 20-some thousand on top of that, a total of 72,000 diagnoses that are commonly used on OASIS and on billing. So what are called questionable encounter codes, QECs, diagnoses that don't appear on CMS list, are a key factor and need to be watched very closely. You need to know when you're taking on a care of a patient that a QEC is involved, so that you can go back and work with the folks that can get you more information about the cause of care. Often what's wrong with the QECs is that they are symptom codes, and vague, things like other malaise, muscle weakness. Muscle weakness is one of the major diagnoses that's used nationally under Medicare. It tells you nothing about what the agency is going to do with regard to the needs of that patient. Also, an awful lot of codes have the phrase unspecified in them, and most of those are disqualified. So having the right diagnosis is critical. Once you know that you've got a valid primary diagnosis, what's the least amount that you can expect to get for a 30-day period? Using that 1883 figure that I mentioned and assuming that the labor rate for the patient CBSA is a 1.0, the expected amount the minimum amount would be $901. That's $901 per 30-day period. That occurs in a situation where you have the lowest case mix. That's a case where you have a community referral, late timing, a low functional score, no comorbidity, and where the clinical grouping is managed medications, teaching assistance, surgical aftercare, that particular grouping, which receives the least reimbursement at the front end. To that, you can add dollars based on the specific clinical grouping, and the one that adds the most is wounds. It's very clear here. Neuro rehab is a close second. In those cases, you're dealing with just about $1,500 total for a 30-day period, and presumably continuing at that amount on into the next 30-day period. Some, like GI, add significantly less, and surgical aftercare, of course, is zero because that's the baseline. The institutional, the referral, and the timing circumstance, the item that generates the most revenue is the institutional referral for an early payment period. And in that case, you add another $1,104. So now you're at $2,600 for that first episode, still at $1,500 for the second, the first payment period, $1,500 for the second payment period. You could end up with a late institution that still adds significant money to the resources available to you. The functional score also adds significantly. A functional score can add as much as $600 if you've got a high functional score for MMTA surgical. These vary a bit with regard to the clinical grouping. On average, you're looking at 500 at the high level and 300 at the medium level. When you consider that that applies potentially across two payment periods, you're now adding as much as $1,200 to the amount that's available for the 60-day period. The thing about functional add-on is that it comes directly from OASIS, and we have a history in the industry of under-assessing functional. We often have related over the last 20 years the number of therapy visits being provided to the functional level and found that they were totally out of whack. People seem to assign visits based on an intuition of what the patient needed, but to gloss over the activities of daily living and so forth that determine their functional score. And the net effect is that coming into PDGM, you potentially will dramatically reduce reimbursement if you don't get those scores properly assessed. The concern is properly assessed, and they need to be assessed on both the start of care and the recert. And to that end, CMS has had to add a couple items to the OASIS for the recert so that it would have everything it needed, and that'll be a part of OASIS D1 when it comes into play in January. What you need to do is you need to monitor performance of organizational units, individual staff, look at this across time. This is the way that your numbers can help you. Those are not difficult numbers to come by in a system, and generally you have the tools to be able to do that. And in particular, if you can compare individuals, you will find that people will consistently vary despite the fact that you can't discern anything that's really different about the population that they're being assigned to serve. There's also a potential increase on comorbidity. And this one, I think, has been talked a lot about, but I think people may be extra hopeful about what this will do for them. The payment will increase by $113 for a 30-day period if you get a low rating as opposed to none, and 3 times that, $339 for a 30-day period if you get the highest rating. But when you look at current data, you see that it seems as if you would normally expect that high rating about no more than 10% of the time, and the low rating probably about 35% of the time. Next slide, please. When you look at how these things are put together, it becomes complicated. There are 1,100 diagnoses that can figure in the scoring of a comorbidity if they're there as a secondary diagnosis. But 1,100 out of 42,000, so about 2.5% of the diagnoses are really relevant to the comorbidity section. And if any one of those 1,100 diagnoses appears as a secondary diagnosis, you will have a score of low. However, to get a score of high, you'll have to have 2 diagnoses from 2 different subgroups from among many different subgroups, only some of which count. It becomes very difficult to chase through and make sure that you've got the diagnoses you need. The next slide will show that. Here are some examples of pairings. So diabetes with foot ulcer together with Parkinson's disease. You've got an endocrine 3, which is one grouping, and a neuro 5, which is another grouping. When you see neuro 5, you can immediately infer that there's a neuro 1, 2, 3, and 4. There are a lot of different groupings, only some of which, only 34 or only 20 of which actually come into play in this calculation of comorbidity. So where I come out is go ahead and put down the diagnoses that apply to the patient, that apply to the work you're going to do, that the doctor has ordered, that the chart is going to support, and let the chips fall where they may with regard to comorbidity. Now, CMS expects that you're going to try to finagle the data for the comorbidity value, and they're going to be watching that. And my reason for saying that is that that's been one of the arguments they used as to why they needed that 6.42% behavioral adjustment. They'll come back on that, certainly. But I think there are other more important things to work on. When you put it all together, you've got almost $3,300 for the first 30 days and another $2,100 or $2,200 for the second 30. The reason for the difference being the fact that the second one doesn't qualify for that early institutional stipend and drops that $1,100. You've got $5,400 for this wound care patient for the 60 days to support their care, as long as you do 5 visits in the first 30 days and 3 visits in the second 30 days. It would be really helpful if you can know at the onset of care what the LUPA threshold is, and there are tables that make that all available so that it's possible to see exactly what that threshold level is. And we have those available if you go to axxess.com/PDGM. There are a whole variety of tools available, and they would include tables that help you to see the case mix and the LUPA thresholds for each of the 432 HERGs. So you need to watch your primary diagnosis. You need to be able to get patients into care quickly when they're referred. If they've gone to the community and are now being referred to the agency, but they left the hospital maybe, say, 12 days ago, you want to get them in the next couple of days. So you've got to have flexibility in handling your staffing. And you want to be able to also have flexibility when you manage your visits to avoid LUPAs that could happen because of absenteeism or illness or whatever that where you would have missed visits. One tool that Axxess offers, Axxess Care, allows you to quickly apprise available qualified caregivers of a visit that needs to be done that they can apply to do, and it makes it possible to splice into your staffing additional help at these critical points. Tools like that will make a big difference as you get into PDGM. If we go beyond the individual calculations for the individual assessments and put it together, let's see what happens with agencies. Now, CMS has predicted that it'll be revenue neutral. There'll be winners and losers, but it'll balance out. That it won't necessitate additional billing, and that it will reduce the number of LUPAs. I think all three of these assertions are wrong. And we'll look at some examples. But keep in mind that when CMS has talked about this, they never talk about what the impact of the QECs is. They never talk about how hard it is to get the information from the hospitals, from the doctors, from the nursing homes that you need in order to be able to properly diagnose someone. Before we get to the scenarios, let's talk about what possibly can happen and think in terms of those 60-day periods that we now have. We're going to be dealing with 60-day episodes because that's what the OASIS is driving. But you're going to have situations where you don't get anything at all, as we've talked about, because of the primary diagnosis. Secondly, you may have situations, and probably 25% of the time or so, where you have a 30-day period that gets paid for, and then there's nothing for the second 30-day period because the patient was discharged during the first 30 days. In this case, you're going to get reimbursement that's going to be about 80% of what it would have been under PPS for that 60-day period. You have also circumstances where you're going to have LUPAs in one or both of the payment periods. I think this is going to happen more than 10% of the time. And the payment will be better than it has been, particularly if you have a LUPA just in one of those payment periods and not in both. It'll be better than what it's been under PPS for LUPAs, but there'll be more of the LUPAs. Finally, you're going to have that 50% or so of your patients or of your episodes where you receive full payment for both periods. And there you should expect, a good 5 to 10% more in revenue than you would have seen under PPS. In this particular situation, we're looking at an agency. This is real data, an agency that has enough QECs, non-groupable diagnoses, to be able to generate a loss of $45,000. This kind of thing does not show up in the CMS analysis. The assumption is that all your diagnoses will be proper. So it's out there. It's part of this agency's situation today, and they have to work on that. You're also going to have about, in this case, they've got 5%, a relatively small proportion of cases where they have 30-day episodes, because in fact, they've got a huge number for which they're doing full pay for both periods. This is a case where they're taking care of their patients across more of the 60-day period. That's giving them some revenue that help. They're generating a surplus on those ones where they get both payment periods. And the LUPAs, they actually, as I say, it pays a little better, so they actually are up a little on LUPAs in comparison with what they had before. So what they've done on the longer treatment that overlaps both payment periods is that they have compensated for the QECs, and they'll actually see a surplus. Scenario 2 is a situation where there are gains in that full pay circumstance or option, but they don't compensate for the 141 bad diagnoses. And you can see that there's a significant loss. It's going to amount to about 10% or 8% maybe of the revenue of the agency as a result of the heavy dosage of QECs. There's a little loss on the 30-day episodes as well, and we'll see more of that in the next slide. In this slide, what we've got is a loss everywhere you look. And there's a substantial percentage, 57% of episodes that have full pay, but a big loss. And the same thing is happening for the QECs, much more of a loss than the 10 or 20% that I would have expected. In this slide, we look at that same agency, number 3 there, with the data that we get by comparing all of the clinical groupings. It's the same analysis, but done grouping by grouping. And where do we see the losses? Neuro rehab and musculoskeletal rehab. Those are the two that really have a problem. And you look at that and you say, whew, now there an awful lot of those obviously are full pay episodes. What's happening? In both the case with the full pay and the 30-day, what's happening is that they've been having they've been enjoying very high revenue for an awful lot of rehab cases where they were doing 14 or more therapy visits. You probably know that from the PPS, the way in which PPS payment is calculated, that there are thresholds for numbers of therapy visits. And when you get above that 13 visit level, you suddenly have jumps of $1,000, $1,500, $2,000 in the payment for the 60-day period that are triggered by that number of visits. This agency has got a large number of those. I took a look at this kind of phenomenon for a similar agency and similar sized agency and found that when you cleaned those out, they had surpluses across the board and did very well. So the question is, you're going to get less revenue. You're not going to lose necessarily. It depends on what your costs of doing business are, but you're going to have to look at how you get the best outcomes with the costs as low as possible. When we group all this stuff together and look, we can try to see things on a scorecard kind of basis. These are just a variety of numbers, just a small set that you might look at, but where it's been possible to compare case managers across an organization to see how they rank in relation to each other with regard to things that you would think would be pretty uniformly done. And you look and you see that there are definite high people that are consistently low. And so with a scorecard, you can look and say, this person's got 5 different areas that are highlighted where they're right at the absolute bottom of the scale. Let's take a look and see whether they need training, whether they need supervision. You can do the same kind of thing with teams, with assessing clinicians, and then you can also compare ultimately with other organizations. For just a final set of tools, the kind of thing that is very helpful is to be able to get frequency distributions, which show you your distribution of your clinical grouping, your comorbidity scores, your referral types, et cetera, your top questionable encounter codes, and then give you the ability to drill right down to the patient level, so the payment period level, so that you can see where this is happening and dig in. Again, it's good to be able to couple this tool with the look at the scorecards, which may suggest a pattern, and to see what is actually happening. And here's where I turn things over to Aaron to talk about what he's been able to learn about how PDGM will affect the industry using data that looks at things on a national basis. Aaron?
All right, thank you, David. We're going to shift gears here just a little bit and look at data in a little bit different way, and in particular using some of the data that CMS has made available, and this was actually part of the analysis that CMS did when they were assessing the budget neutrality piece or aspect of this new payment model. So one of the things that CMS did, and it was very helpful, and I can't recall a previous time when CMS has done this, but when they released the proposed and the final rule, which contained PDGM elements in it, or that structure, what they also released was a file that is available right now. If you were to go to the CMS Home Health website then you would find there's a link that would take you to ultimately to a spreadsheet that you can find that it provides an estimate of the financial impact of PDGM on all Medicare certified home health agencies. So it's a fairly simple spreadsheet. It indicates the provider number or the P10 number of agencies and a few pieces of geographic information about those organizations, and then it gives an estimate of what CMS was expecting the impact to be of PDGM on each agency, which is great. And so if that's something that you haven't had a chance to look at, certainly when you have time, please do so. But there's a lot of data behind that, of course, and getting into the granular pieces of individual episodes and claims that of course make up that on a composite basis. And so what CMS did as another step was make that information available. And so it's very raw. It's essentially pulling together claims and OASIS pieces of data. But one of the things that's really interesting about this, and David pointed this out a moment ago, is that even though the PDGM is intended to be budget neutral, when you start looking at individual regions or states, and certainly at the provider level, then it certainly takes on a different characteristic to where the impact felt on those various levels will not be budget neutral, because there will be some organizations that, based on their characteristics of patients, will come out more financially advantageous, and some that won't fare as well. But this data that CMS released, it was based on 2017. So of course, back in 2017, we didn't know PDGM or all the payment elements like we do now. But CMS did their best to essentially apply the PDGM payment structure back onto 2017 to help provide insights on to what this would look like. So it really offers a great opportunity not only to dig into certain, again, states and regions and providers' data, but to really give us a feel for going forward, what are the types of data elements that we hope we'll have access to and that we believe will be really relevant as we continue to come up with, what are those really key performance indicators for any particular organization that they'll need to be managing under this new payment model. So I think this data can be extremely useful for a number of reasons. And so one of the things that we did, and we thought this would be helpful not only for our own understanding, but just as we try to learn more about the impact of this model to our industry, is we took a look at our home state. So just at a high level, so I'm based in the state of Missouri. And so we said, well, what might the impact be on the state of Missouri? And overall, what CMS had estimated for all the providers in Missouri is a decrease in payment under PDGM by 3.4%. Now, when you start to stratify that a bit, it is pretty extreme. It can be extreme. So, for example, there are 43 agencies that were expecting a decrease of 10% or more, and there was a group of 31 agencies that were showing a decrease in that 5 to 10% range. There was 27 that were in that 0 to 5%, but yet there were 62 agencies that were showing an increase. So, there again, you can start seeing a lot of extremes when you get to that provider level. But one of the things that's really interesting to keep in mind, if you're looking at any of the CMS data, and this is no exception, that this estimated impact is before CMS's application of those behavioral adjustments. And David mentioned that also during his slides, but essentially those are behaviors that CMS is expecting will occur and could potentially artificially increase the payments going towards individual agencies. And so to offset that, they have put on the table this idea of reducing payments by 6.42% from the get-go. Now, there's a lot of advocacy around trying to get that number either completely taken off the table or at the very least reduced. So we'll see what happens between now and January. But if that was the case, then really these providers in Missouri on average would be not looking at a 3.4% reduction, but closer to 10% when you then apply a 6.42% on top of that. So really important to think about that. But when we think about this, we want to say, well, what does this look like when we start breaking down the data according to the payment elements? And so David's already walked through this. I'm not going to walk through what each of these means, but just as a reminder, these we have these new payment elements that form an HHRG. We're accustomed to an HHRG. We've had that for nearly 20 years. Each of those has its own case mix weight, which is then applied to that national standard rate. And of course, we have a wage index adjustment too for the place where the patient lives. And so those are the factors that are kind of rolling into the payment for any given patient. So when we start looking at each of these, and again, this is all using the CMS data, and starting with admission source and timing. So we've got 4 different combinations here: community early, institutional early, community late, institutional late. And what does that look like? So in the state of Missouri, you can see the biggest population of PDGM periods fell into that community and the late. So they were followed by institutional and early. And when we've looked at a lot of different states, really the characteristics here, there's certainly been variations, but by far what we've seen is the majority of those periods fall into that community late, which really makes a lot of sense if you think about the fact that one of the goals of home health certainly is to reduce or manage any sort of readmissions to acute or post-acute care. And so while a patient may come to your care and they're from an institutional setting while they're under the care of home health, you're trying to keep them out of those settings. So you would start to see a mix of community periods as patients are on service, and then also because only that very first period qualifies as being early, the longer patients on service, then those subsequent periods are going to be late, so you'd start to see a higher population of those. So the numbers started to make a little sense. But we also wanted to look at what are those PDGM periods according to the 12 clinical groupings. And so really what this information is doing is just trying to rank those from the highest volume down to the lowest volume. And again, this is specifically for the state of Missouri. And so in this state, the top grouping was MS Rehab, followed by cardiac, wounds, respiratory, and neuro rehab, rounding out the top 5. And one of the things that we have identified or observed, I should say, when we've looked at various states and regions, that the top 5 clinical groupings, which again is tied back to the primary diagnosis, have mostly been represented by the 5 you see here. Now, certainly in some states, we see maybe cardiac is the top, followed by rehab, and instead of neuro rehab being the 5th highest, maybe it's the 3rd highest, but it's tended to be these 5 in some potentially different sequence. And in this case, in the state of Missouri, these top 5 actually make up 60% of all of the clinical groupings. So that's just been kind of interesting. When we've looked at individual agencies, again, we've seen some pretty similar patterns. But you'll notice that QE group there over on the far right, and David's already talked about these, what CMS classified as, or I guess termed, questionable encounters. And really this is representing those PDGM periods that had a primary diagnosis that was used in 2017, that under the 2020 payment rule would no longer be payable as a primary diagnosis. And so if we were looking at this and saying this was representative of a specific agency, and that agency had 14% of their periods that were falling into that QE column, then what we'd say is, boy, there's a great opportunity between now and in January for that agency to really identify what are those codes that are being used as primary today that are not going to be allowed under PDGM, because that's a great opportunity to start really assessing should I be using that diagnosis code, or can I get more information about the patient or from the physician that would allow us to get more specific of a diagnosis? Because a lot of those diagnoses that are not allowable, certainly not all of them, but a lot of them under PDGM as being primary, the reason behind that is CMS feels like the diagnosis is not specific enough to help them understand really the needs of the patient, so that as we move forward under PDGM and data begins to accumulate from the claims and the OASIS, CMS is always looking at, are they paying adequately? How do they need to make adjustments? And with the diagnosis being such an integral part of the payment, they really are looking to have as specific information as they can. Well, the next thing we looked at was the functional grouping, and David alluded to this earlier, in a lot of the analysis that his team has done has certainly seen some variations in that functional scoring, which we're talking really about the OASIS assessment now, those activities of daily living, the questions that drive payment today under PPS. It's really those same questions under PDGM that are also driving payment in this particular area, with the addition of a couple of new questions, or not new questions, but new payment-weighted questions for grooming and risk of hospitalization. But one of the things that we might expect to see here from just a statistical point of view is bell curve. I mean, if you're working with a lot of data, you tend to expect that when you start slicing and dicing, and that's not the case here with the Missouri. As you can see, it's more of a downward stair step. And what this is indicating is that 34.8% of these periods fell into the low functional impairment, 33.7 were medium, 31.5 was high. And when we're talking about those scores, the low impairment means that the patient had a low need for assistance versus a high need of assistance. And certainly with the focus of home health, we would expect that it wouldn't seem uncommon that a lot of those patients would fall into that medium range or maybe the high, rather than the majority of them falling into the low. And so what we believe that this is representing are some opportunities for agencies to really look at their functional scoring and make sure that they are capturing that information in the most accurate way. It certainly has bearing on your payment today, and under PDGM, it continues to have a significant weight on the payment. So rounding out the payment elements under PDGM is the comorbidity adjustment. And so here again, we're talking about the diagnosis coding, but as opposed to the primary, here this is representing all of those other diagnoses. And so on any individual claim, a claim could hold up to 25 diagnoses, so that would be one primary and then 24 other diagnoses. But one thing that's kind of curious about the data that CMS released, and of which you're seeing represented here, is the comorbidity information was actually based on the OASIS data and not the claim data. And the reason that that's significant, I believe, is because the OASIS really only holds 6 diagnoses as opposed to the 25 on the claim. So I think if we were using claims-based information here, we might see a little bit of a different mix between those periods that did not have or did not qualify for a comorbidity adjustment versus those that got the low or the high adjustment. Because certainly if you're working with more diagnoses, you have more opportunities for there to be one of those that might qualify for the comorbidity. But again, nonetheless, you can see that 53.6% of the periods did not contain any comorbidity diagnoses that carried any payment value. So again, just kind of giving us a baseline of how things looked back in 2017 based on the practices that were in place at that time. One of the other things that we were really curious to understand, and here again, we're still looking at the state of Missouri here just as our example, was because we are moving from the prospective payment system, PPS, over to PDGM, and we're trying to wrap our heads around what does that look like financially for these clinical groupings, MS rehab, cardiac wounds, so the top 5 in the state of Missouri, how does that look in comparison from PPS to PDGM? Are these clinical groupings expected to show an increase or a decrease in payment? So what you're seeing here is that for MS rehab, so that represented 22% of the periods from the CMS data, that it was showing a 13% decrease in payment, whereas cardiac was showing a 2% decrease, wounds showing a huge increase in payment, which is great, 24% increase, because we all know that wound care patients, they tend to require a lot of visits, so you have a lot of utilization there, but they also tend to have very expensive medical supplies. And so it's great to see that if we're moving, or as we are moving to this new payment model, that we're seeing, I believe, a more adequate payment for those heavy cost patients like wounds. So it's good to see that increase. But then neuro rehab and respiratory were showing a 9% and a 5% decrease. Now, again, keeping in mind that this is all based on the 2017 information, and if we're looking at an individual agency's data and able to dig deeper, we could gain some insights into why this might be, and that's what we're going to take a look at next. So, you know, we hope that what agencies are doing today as part of their preparation is really trying to understand their own impact and then why. If you're showing an increase or a decrease, why is that? And how can you go about assessing that information? So here's just one example. So we took 2 agencies. We'll say agency A and agency B. And on the surface, they look pretty similar. They're both freestanding for Medicare purposes, so meaning they are not set up as a department of a hospital or a skilled nursing facility. These were both for-profits, both in an urban area, happen to be in the same state, and as you can see, right at about $4 million in annual Medicare revenues. And yet, the agency A was estimated to see a 10% increase in payments under PDGM, whereas agency B was estimated to show or to have a 12% decrease in PDGM. So, you know, on the surface, these two look very, very similar. But, and David really made this a point earlier, that under PDGM, the payment is really based on these patient characteristics. So what is it about the patient characteristics of these two organizations that is so different that it's producing these kind of variations in the impact? And so that's what we wanted to do. And so the first thing that we did is say, well, let's look at each of these payment elements, starting with admission source and timing, and see, is there a significant difference there? So agency A's data is in the top graph, agency B is in the bottom, and just, you know, visually, there's not a great amount of variation. You can see very similar patterns. Where there is variation, certainly, is that agency B is getting more of those community early patients than agency A. Not a huge amount of difference there, but otherwise they look fairly similar. When we looked at the clinical grouping, that's where we certainly start seeing some pretty distinctive differences. So agency A here on the left, we can see very quickly that the majority of their population was cardiac patients, and then followed by MS rehab. They've got respiratory, they've got the MNTA other, contrasting that with agency B, which between the neuro and the MS rehab category, that represents 36% of their population. And so right away we can see that this is an organization that, again, historically at least, has been very heavy in the types of patients that require a lot of therapy. And they also have a good amount of cardiac and wound patients as well. But one of the other things that's really curious about these two organizations is that agency A, only 6% of their PDGM periods were falling into that QE category. So they had a primary diagnosis that couldn't be matched to one of the 12 clinical groupings, compared to this agency B, where those questionable encounters or those QEs represented 20% of their population. So that tells us a little bit about their coding, that, again, because this was from 2017, that the primary diagnoses that were being used by agency B back in that year, 20% of those would not be allowed as a primary under PDGM. So they certainly have some opportunities to be addressing their coding practices. So the next thing we want to look at is that functional impairment. So we're just kind of following those payment elements. And again, this is coming straight off the OASIS, so it's representing the assessments being done by the clinicians. And I think what really stands out to me personally here is that you see more of that bell curve or that bell shape for the agency A, whereas you see more of the downward stair step for the agency B. And so, 42% of agency A's patients are falling right in the middle at the medium impairment level, whereas agency B, 43% of their patients were in the low impairment. And that really struck me, because I thought, gosh, that seems a little odd when the previous slide we understood that 36% of their population was falling into the neuro or the musculoskeletal rehab clinical grouping. So, this is a great example of where we think there's potentially some underassessment of patients in their activities of daily living as suggested by this data. So a great opportunity for this agency B to assess that. And next on the comorbidities really not a huge difference between the two organizations, but what it does indicate is that agency B, that 52.5% of their periods did not qualify for either a low or high adjustment, compared to agency A at only 45%. So again, we could say agency A appeared to be doing a little better job, or a little more representative job of capturing those comorbidities. But the next thing we really want to understand is, that's good at a high level, but what about when we start to really try and dissect these individual clinical groupings, and knowing that MS Rehab for agency A was, that happened to be their number 2 volume in the clinical grouping, compared to agency B was their number 1. What are some significant characteristics here about these two agencies? And one of the things that we were interested in here is, what is the average PDGM payment expected to be for the two agencies? And it's kind of hard to see. It's right in that middle graph under that margin analysis, the very first bullet on the left-hand side. So agency A is looking at an estimated $1,889 per 30-day PDGM period for its MS Rehab patients, compared to agency B, which is at $1,844. So really not a significant difference, very, very close. However, one of the other things that really stood out is that agency A, their average functional score or functional grouping was at a 2.1, so a little better than median, whereas agency B was below 2 at only 1.7. So again, it's telling us or making us question whether those functional impairment levels were really adequately assessed. And one of the things that we also identified here is that the agency A, when we look at their PPS, so PPS episodes, just on average, these MS Rehab patients were getting 10 therapy visits per episode, whereas agency B, they were getting 15. Now, regardless of the needs of the patients, that was the intensity level. But when we think about the conversion of PPS to PDGM, and David articulated this in his slides, we know that one of the foundational principles of PDGM is there are fewer dollars going into those neuro and MS rehab types of patients, because there's more dollars going into the wounds and the more nursing intensive types of patients. So that's just sort of a fundamental construct of PPS. So when you have an agency that's historically done a lot of therapy, had a lot of those types of patients, getting a higher payment under PPS, likely that will not be as high under PDGM, which isn't to say that the payment under PDGM is not adequate. It's just not as high as it has been under PPS. And I think that's what we're seeing for this particular agency. And really, though, on this next slide, what we can start to see is that Agency A had actually a higher population of institutional patients, a higher, and also had a higher population of early, which from a payment perspective is really in their favor. But in that functional grouping score, you can see there again, and we're talking MS Rehab patients here, it looks like they're really doing a different type of assessment in capturing that functional scoring. As you can see, only 28% of their patients fell into that low functional impairment compared to this other agency, which was 47% of their patients were falling into that low impairment. So one of the things that we could take away from this is say, boy, if this agency B, they were looking at a 12% decrease in their payment under PDGM, but where they could certainly have some influence over that is if they really look at their assessment patterns and say, are we really capturing the data correctly about these patients? Are we really doing the most effective job assessing? Because, gosh, those scores sure look different from the state as well as this other comparative agency. So I think that'd be a great opportunity for them to potentially offset what might still be a decrease in their payment, but maybe it doesn't have to be 12%. But also looking at their coding to make sure that we saw that 20% of their PDGM periods were falling into that questionable encounter grouping. So they have a great opportunity to change that and again make sure that they're capturing the primary diagnosis in the most correct way to place that patient in the most adequate payment category. So, from a learning perspective, I think we can take a lot away from this data, and I hope that this gives you some ideas about how that you might be able to go about doing your own assessment. And, maybe you don't have this level of detail, and that's okay, but, you probably do have some data that maybe you just haven't been able to figure out a great way of doing your own assessment. So I do hope that this gives you some ideas on how to do that. So when we look at the two agencies, I think Agency A, I do think they even had some opportunities to really look at their comorbidities, whereas Agency B, definitely the comorbidities, looking at their functional scoring, their primary diagnosis coding, but I think also maybe looking at the utilization, making sure that they're really making the best use of every visit, because there could be some opportunities there to better align their utilization with the needs of the patient, which from a cost containment perspective is certainly a strategy we're always aiming for. Well, with that, I'm going to turn it back over for just a couple of wrap-up comments here by the folks at Axxess.
Thank you, Aaron, and thank you, David, for sharing your wisdom as we continue to prepare for the implementation of PDGM. I'm sorry, everyone, but we have run out of time to address questions today. However, we will follow up with those questions that were not answered directly through the chat. We will follow up through email to communicate with you and get you the responses that you need. And also, I just want to remind everybody that we will have the webinar, recorded webinar, as well as the presentation. We will be sending that to you by email as a follow-up to today's webinar. Thank you for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions.
Thank you for joining our on-demand training today and for choosing Axxess, a provider of innovative, cloud-based software, services, and solutions to help home health organizations improve patient care and grow their business. Axxess is the only healthcare technology company approved to award continuing education credits by the American Nurses Credentialing Center and is also the most recommended home health software on Software Advice. You can watch more on-demand training videos through our software or at axxess.com, where you can also find tutorials, blogs, white papers, and answers to frequently asked questions. Thanks again for choosing Axxess.